Hello, and welcome to today's Lunch and Learn presentation, Hip and Knee Health. Get moving again. I'm Dr. Steve Reinches, the President and CEO of North Kansas City Hospital. Thank you for joining us. Chronic hip or knee pain can impact your daily life and keep you from doing activities you enjoy. From diagnosis to treatment to rehabilitation, our orthopedic specialists offer a full range of conditions, a range of services for conditions affecting bones, joints, ligaments, tendons, muscles, and nerves. We're extremely fortunate to have one of our orthopedic surgeons here with us today, Dr. Dustin Woyski with Northland Orthopedics and Sports Medicine, is here to talk about common causes of hip and knee pain and various treatment options. Dr. Woyski is a fellowship-trained orthopedic surgeon. He received his medical degree from the Kansas City University of Medicine and Bioscience College of Osteopathic Medicine. He completed his residency at St. Anthony Hospital and his fellowship at Duke University Hospital. After Dr. Woyski speaks, he'll be joined by Jason Calder, a physical therapist in our outpatient rehabilitation department and our Employee of the Month. Jason will share information about our highly successful Move Plus program for people with chronic pain. Please help me in welcoming Dr. Woyski.
Dr. Reinches, thank you very much for that kind introduction. Thank you to North Kansas City Hospital for inviting me for this talk, and thanks everyone for joining us. So I'll be talking a lot about hip and knee health. In my practice, I typically treat lower extremity injuries and disease, so mostly hips and knees. But I want to start it off a little bit about myself. I grew up in Northwest Missouri. You can kind of see that small little tag up there. That's Agency, Missouri. I think the population's around 600, but that's where I grew up and went to school K through 12, just there in Fawcett. It's right up the I-29 corridor if you're going from Kansas City to St. Joe. So it's been good for me to be back home. I did undergrad in molecular and cell biology up at Missouri Western St. Joseph. As Dr. Reinch just said, I did med school just down the street at Kansas City. We spent 5 years in Oklahoma City in residency, which was long and brutal, but I really enjoyed it. And then we spent a year up in Durham, North Carolina for my fellowship in hip preservation and reconstruction. And then now I've been with Northland Orthopedics and Sports Medicine for almost 2 years. So just a short agenda that we're going to be discussing today, looking at knee and hip anatomy and pain, different parts of the joints and what can cause pain. What we typically start off with standard in-office treatments, and then kind of the role of physical therapy in joint health. And as Dr. Reinch just said, Jason, the Employee of the Month, will be talking about Move Plus program at the end. So just briefly going over knee anatomy, the knee is composed of 3 different bones. It's a hinged knee joint or hinged joint. We start off with the thigh bone or the femur. Across from that's going to be the tibia or the shin bone. And overlying that's the kneecap or the patella. The undersurface of the patella is covered in cartilage, and you can see that the end of the femur and the top part of the tibia is also covered in cartilage as well. And cartilage defects, whether they're focal or small, or all the cartilage is gone, and what you'd see in arthritis, that can be a source of pain. The knee has multiple ligaments that cross the joint. There's some on the outside, the lateral collateral ligament, medial collateral ligaments. Those can be involved in tears and sprains, typically in sporting injuries or high energy injuries, such as a car accident. Probably the most well-known ligament of the knee, the ACL or anterior cruciate ligament, and then behind that, the PCL. Again, these can be involved in sporting injuries or traffic injuries as well. And then the menisci, there's the lateral meniscus, which is on the outside of the knee, and then the medial meniscus, which is on the inside of the knee. And these are a common cause of pain, especially in older individuals that have degenerative tears, or also young individuals can have acute tears with injuries as well. As far as pain sources, again, arthritis is a big one. That's one of the most common diseases that I see and treat in my office. We talked about ligament ruptures and tears that can happen with sporting injuries, as well as traffic injuries, meniscus ruptures as well. Muscle soreness and tendonitis, I didn't picture the muscles, but there's quite a few muscles that attach to and go around the knee. They can be sore from overuse. They can be sore from inflammation as well as weakness. Malalignment. Malalignment is essentially where the bones align that are abnormal in nature. You can see people that have knock knees, also patients that are bow-legged, and malalignment can be a significant source of arthritis early on just because the mechanics of the knee aren't normal. Instability, there's different types of instability. Gross instability, which you think about when patients have a knee dislocation, or maybe if they have an ACL or PCL rupture where the knee moves around quite a bit. There's also an entity called microinstability that usually stems from weakness. Maybe there's a little bit of muscle deficiency in some of the muscles around the knee, and those patients can have subtle subluxation or movement of their knee, which causes pain. And then weakness is probably one of the ones that I don't think people focus on enough, but I see it quite a bit. And that's where I think physical therapy serves a huge role in the rehabilitation of both knee and hip pain, is identifying those patients that have weakness in certain muscles, restoring strength of those muscles, and as well as restoring kind of the firing cadence and the normal activity of those muscles. Since arthritis, again, is something that we see quite often, we'll kind of talk about what a normal knee x-ray looks like, and abnormal, and then obviously on the right, what a knee replacement looks like. So I like to show in my clinic patients their radiographs and go over with them. I think it involves them in their care and also gives them an idea of what they're seeing and what the potential sources of pain are. So if you look at that, again, going back to the image we saw before, the thigh bone or the femur, the kneecap is a little bit difficult to see overlying, but that's that small round structure there. And then you can see the tibia or the shin bone. And what I'm really looking for is, again, their alignment. Are there large angles that aren't normally there? And then I'm looking for the dark stuff in between. So where that dark stuff is essentially the cartilage. Cartilage is not as dense as bone, so it's not going to show up on x-ray very well, but you want that spacing to be in between the bones, and you want it to be symmetric or equal from one side to the other. So this is a very normal appearing x-ray on the right. The middle x-ray is not so normal. You can see that there's asymmetry between where the cartilage is on the outside, as well as the inside is decreased. This is what we typically term bone-on-bone arthritis. You can see small extra chunks of bone. These are what we call osteophytes. And those are typical signs of arthritis. And once you get to this point, as far as surgery, arthroscopy is not going to be an option, but a knee replacement would be. But if you're seeing me for the first time, I'm going to give you a lot more options than just a knee replacement to start off with. I think replacement is a very good surgery, but those are for patients that have failed conservative measures. And this is essentially what a knee replacement looks like. I think prior to medical school, I thought basically just make a big cut on either side of the knee, take out the knee, put in a new knee like you're changing out brake pads. But it's a little bit more elegant than that. It's more of a resurfacing where we make multiple cuts on the end of the knee or thigh bone, and then we'll cement typically this metal implant. We do the same thing for the top of the shin bone or tibia, removing that arthritic surface, replacing with metal. And you can see, similar to a normal knee x-ray, there's kind of space in between those two metal implants, and that's covered with plastic. And that's how we essentially restore you back to a normal knee. Moving on to the hip. The hip is somewhat analogous to the knee. It does have bone and soft tissue structures around it, but you can see it's more of a ball and socket joint. So it's inherently going to be a little bit more stable than the knee, but there are some ligaments that go in and around the knee. When I look at the hip, I'm looking at what we call the acetabulum, or that's the socket. It should be nice and round shape. The ball should be nice and round shape, and that's what we term the femoral head. Again, they're going to be covered with cartilage as well. And that's, that can be a source of pain if there's, again, small defects in that, or large focal defects where all of the cartilage is gone. The hip has an interesting structure called the labrum. On this picture, it looks like a small little triangle. It's not pictured here on the right, but essentially it lines the outer ring or edge of the acetabulum or socket. And what it does is it helps restore or maintain stability of the hip by providing a suction seal. The problem with it is that it does have quite a bit of innervation nerve tissue to it. And so if you have a labral tear, whether it's acute from a traumatic injury or degenerative, or happens over time in the incidence of femoral acetabular impingement, it can be very painful. And kind of a clue that people are having pain that's coming from the hip joint is a lot of patients will say that their groin hurts. They may think they have a groin pull. So oftentimes arthritic type pain or pain that's coming from the joint, even if it's labral tear, you'll feel kind of more in the groin area rather than the outside part of the hip. And again, similar to knee, that like I said, there are some ligaments around the hip, but they're not as robust of a structure as you would see in the knee. So typical pain sources, arthritis again is going to be a leading cause of pain in the hip. And again, that's where there's either small focal defects in the cartilage or it can be global cartilage loss. In patients that have arthritis, it doesn't necessarily measure with their pain. You may have really bad arthritis on an x-ray but have minimal pain, or have very minimal arthritis but have a lot of pain. And you just have to treat those patients a little bit different and kind of know those things. We talked about a labral tear. Again, we didn't picture the muscles of the hip, but there are quite a few muscles that cross and interact with the hip, and those can cause pain as well. Something that I see quite often is something called gluteus minimus and medius tears, which are attached to the side of the hip, and a lot of people see that in something called trochanteric bursitis. You'll have pain when you sit down, you have pain if you touch the outside of your hip, or you have a difficult time sleeping on that side. That could be a sign of either a muscle tear or just generalized trochanteric bursitis. Abnormal shape, we'll see a few examples of these in just a little bit. But again, similar to the knee, you want that joint to be nice and concentric. So you want a round ball and a round hole or round socket. And if those are abnormal in their shape, then that can lead to arthritis very quickly. Instability, again, similar to the knee, you can have instability of the hip, and that can be gross instability, though that's more rare. And that would be essentially where your hip dislocates. And you usually only see that in like car accidents or motorcycle accidents, things like that, or fall from standing height. Micro instability, where again, like in the knee, there's just subtle movement of the joint, is probably much more common and probably not seen as much in the office that you would think. And weakness is another thing that we look at again. Patients that have core weakness, they can have buttock weakness, your hamstrings and your quadriceps can be weak, and all those can affect the way that the hip works. People that have low back pain or low back arthritis, their spine does not move as well, and so there's increased demands on the hip, and if there's a weak hip, you can have a source of pain there as well. So this is a radiograph of a normal hip, again, just like any other joint, and we used the knee as an example earlier. We're looking at normal structures and trying to find, do they have normal shape? Is there cartilage in between them? So the socket is a little bit more difficult to see than the knee because you're seeing a three-dimensional structure in 2 dimensions. But essentially, this is the top part of the socket. We want it to be nice and flat. We want it to cover most of the ball. Don't want it to be all the way over the ball, but you don't want it to be halfway covering the ball. And then we're looking at the nice spherical or round shape of the femoral head of the ball. And again, we have this kind of nice eyebrow dark area in between the 2 bones, indicating that this patient has a good amount of cartilage. So it's a very nice normal looking hip x-ray. Talking about abnormal shapes earlier, here's 2 examples that I commonly see in my office. The top one is something called femoral acetabular impingement, which sounds like a really big nasty word, but all it means is femur or thigh bone, acetabulum or acetabular, and that's the socket side. Impingement just means they're bumping up against each other. So either there's extra bone here on the socket or extra bone up here on the top part of the femur, and that causes them to bump up against each other in deep flexion activities, such as bending down for soccer, even just sitting for long periods of time can cause pain in these patients. So we use kind of the back side of the femur as a template. This is usually normal. So you have the nice spherical shape kind of tapering down to a cylinder, whereas on the front part, you have kind of this lumpy, bumpy appearance, and that can lead to labral tears and eventual early degeneration of cartilage down the road. This bottom image is somebody that has acetabular dysplasia. So dysplasia just means abnormal formation. They have it a little bit on the left side, but much more so on the right side. So you can kind of see even the contrast from left to right, that the right side looks vastly different. Their socket is sloping up instead of being more flat. It ends roughly about mid portion of the ball or the femoral head. So again, it's very short and shallow. You can see that the ball has started to kind of sublux or come out of the joint, and it just overall has an abnormal looking appearance to it. And these patients can have very accelerated early onset arthritis to where they're having hip replacements in their 20s, 30s, and 40s. So speaking of hip replacement, here's a patient that has had one on the left side already, but they're ready for the right side based off their radiographs, as well as they failed conservative management. But things to look for in a radiograph that I show patients is, essentially that area where the cartilage was before is gone. And now they just have these extra osteophytes or extra bone around here, down here, and it's very difficult to see here, but they also have cysts, and the cysts aren't any tumors or anything like that. It just means that there's cracks all the way through the cartilage to where fluid can get into the bone. And then here on the right side, you can see they've got a brand new hip, new socket again. We have to resurface the socket. We have to somehow get a new ball in there. And the way we do that is we put these, we call them stems, but basically it's a wedge piece of metal that kind of wedges itself in the bone, and we put a new ball on it. There's a plastic liner that goes in between that, and you're up and walking on it the day of surgery. So I can't talk about hip and knee pain without making reference to the spine. So there's quite a bit of overlap. Some patients, they're lucky enough to have 2 or 3 problems where they have knee arthritis, hip arthritis, or hip and knee pain, as well as back issues. Not all back pain is located in the back, so to speak. Some patients may have some soreness and tenderness on the direct location of their back. But oftentimes, if I see people that have neurogenic or spinogenic pain, they can have referred pain where you talk about sciatica. They often have buttock pain that will radiate down the side or the back part of their leg that goes into the foot. They may have associated numbness. And so you can see from this, we call it a dermatomal map, but essentially it's locations of the nerves and kind of where they innervate sensation along the buttock area and the leg. And so most disease, at least that I see, and Dr. Reinches could probably speak to it much more than I could, but you see it mostly in the lower spine and where it transitions from the spine to the pelvis. And my thought process is the spine is relatively mobile, where the pelvis is less mobile. So there's a lot of stress in that area. And so you can get disc bulging, you can get arthritis in your back that can upset or irritate the nerves. And that's where you can get this referred pain. So I was kind of always taught that if you had pain that maybe starts in the buttock area but extends past the knee, you want to make sure that you're looking at their back. So doing a good clinical exam to rule out their back as a source of pathology is something that I think is very necessary if you're going to be treating hip and knee patients. So standard in-office treatments, what are we going to do for you, whether it's your first time, second, or third time coming to our office? My main goal is I want to determine where is the pain coming from. So whether it's hip, back, or knee, where's the location? And then is it inside the joint or outside the joint? Again, that helps me determine what other additional treatments we can do. And usually I'll use injections as well as clinical exam. And then what you tell me as a patient to kind of clue in, is it really coming from in the joint or outside the joint? Obviously, x-rays are going to help us out a lot with that too. Anti-inflammatories. So we typically say NSAIDs, but essentially it's an anti-inflammatory that's not a steroid. So it has this nice big acronym, but you can get many of these over the counter. Ibuprofen is one of those. Advil is kind of a brand name for that. Celebrex and Mobic, these are prescription medications, and not that they're necessarily better. I like them because, Celebrex you can take once or twice a day. Mobic is once a day, and I can't remember to take a multivitamin, once a day. So somebody's going to have to take ibuprofen 2-3 times a day. I think it's just a little bit easier to do prescription based. Topical anti-inflammatories is something that's been around for a little while, but they're now recently available over the counter. So that's been a very good augment to treatment, especially if patients have, outside the joint type of pain. Physical therapy, I think, again, this is a key part of my in-office treatments. I send almost all of my patients, if they're coming to me for the first time, whether it's hip, knee, shoulder, low back pain, to physical therapy. I'm not a physical therapist by training. I'm married to one. She thinks I'm a terrible physical therapist. But patients do get quite a bit better with physical therapy, whether that's land therapy, aquatic therapy. They have different augment therapies that they can do as well. But I think that it's got to be a key part of your treatment algorithm. Whether you're doing injections, oral anti-inflammatories, or anything else, physical therapy has to be a portion of that if you want your patients to do well and get better. Injections, there's multiple types of injections. We'll talk about this here in just a little bit. So talking about anti-inflammatories, again, these are just examples of things that you can get over the counter. There's obviously other ones that you can look at. As far as injections, again, these are kind of the four that are known out there. The top three are ones that I would do and recommend. The bottom one, stem cells, I think there still needs to be more research. But corticosteroid or steroid injection is typically what we start with. It's relatively cheap. It's easy to do. There's not a lot of training involved in order to do these. And insurance essentially pays for them as well. So it's a quick and easy medication that we can use for that. PRP is something that's a little bit newer, though there's quite a bit of research going into it nowadays. Most offices can have these centrifuge machines in their office, so they can be done in office, sometimes same day. So essentially, we're going to be drawing blood from you. It goes into this vial and it gets spun down in a centrifuge, and the heavy stuff's going to go to the bottom, like your red blood cells, and you're left with kind of this thin plasma that has a lot of platelets in it. So that's where they derive the name. And most studies that they look at, especially with knee arthritis and hip arthritis, is that they do as well, if not slightly better, than steroid injections and viscosupplementation. The good part about it is, essentially it's your stuff. So you're not worried about, stem cells or infection or anything like that. The downside is that insurances don't pay for it, and so there's a little bit of an out-of-pocket cost to it. But I think it's a very good option, especially in young patients that you're really worried about their joint health and not damaging any cartilage, as well as patients that have failed other therapies like steroids. Viscosupplementation. Another name for this is hyaluronic acid, which is essentially synthetic joint fluid. This is something that I offer to patients, especially with knee arthritis or knee pain that have failed other treatment modalities, but they don't want to have a surgery. Maybe the timing's wrong for them to have a knee replacement, or they just don't want to have one as of yet. The other caveat is I want to make sure that insurance covers this medication because it can be expensive out of pocket. And the reason for that is our kind of guidelines that are established by the American Academy of Orthopedic Surgeons don't necessarily recommend viscosupplementation for the treatment of arthritis of the knee. But if you have a patient that's tried steroids, they've done physical therapy, they're taking oral anti-inflammatories, they still have knee pain, but they don't want to have a knee replacement, they have to have an option. And this is one option that you can offer them. Stem cells, there has been studies where they look at it compared to the other types of injections, and maybe there's some benefit to it, but there's also a lot of bias to it. And my real beef with stem cells is just the cost of it. You can find any place around town, but they're going to charge you $3,000 to $5,000, $8,000, and they may make claims that your arthritis is going to go away, it's going to reestablish cartilage, but it just simply doesn't do that as of yet. Obviously, there's more studies looking into stem cells and the power of those to see if we can do it, but right now the data is not there. And then placebo effect. So whenever they look at studies to see, do these injections work, they have to compare it to something that they think would not work or not make you better. And so saline ends up being that comparison or that control group. And they found that even the patients that got saline injections, they did get better. So there may be some placebo effect to injections, but my kind of thought on that is it doesn't matter if it makes you better, it makes you better. So, go for it. So briefly, again, I've kind of echoed physical therapy and the role of physical therapy and how important it is in patients with hip and knee pain. But I think it's paramount. It doesn't matter where you fall on the spectrum. If you have tendinitis, if you have arthritis, if you're a preoperative patient, if you're a postoperative patient, I can't stress enough how important physical therapy is. Sometimes it can be cost prohibitive, but I know physical therapists will work well with patients in those situations to try to get you to a home exercise program or something else. But I want patients to really believe in the power of physical therapy because it really does help with your pain and mobility long term. So what can you do on your own? Do you have to come to a fancy doctor's office and do all these things, or what can you do prior to that? Exercise is something that I encourage to my patients, and you may have to find something that you wouldn't normally do because other things you like to do are painful. Maybe running's painful. So maybe you have to get onto a bicycle or do an elliptical. There for a while during COVID, a lot of places that had pools were shut down, but aquatic exercise can be very good, especially patients that have significant joint pain. Weight loss, I think weight loss is a good thing for overall health, but it can also decrease the amount of stress that your joints feel. But I'm not going to tell you that if you lose 100 pounds and don't do anything else that you'll, get rid of all of your joint pain. But overall, weight loss can help a little bit. And all of these are just small little pieces that you can do on your own to really chip away at kind of the big source of pain, as well as joint deficiency. A healthy diet. There are some studies that look at anti-inflammatory diets and decreasing pain. But I think overall, if you just make good, healthy choices where you're, eating things that come from a garden rather than out of a box, that you're going to do yourself good towards your weight loss goal, as well as decreasing inflammation. And I've always found if I eat healthier, I tend to do more exercises as well. Over-the-counter anti-inflammatories, I think we stressed that quite a bit. But what options do we have for patients that can't do over-the-counter anti-inflammatories? Maybe you've had, a gastric procedure where you can't do anti-inflammatories, or a heart procedure, or you're on blood thinning medication. Then I think turmeric is a good alternative for that. Essentially, it's an herb or a spice that they just put in a capsule, and you can take that. And it's been shown to reduce inflammation and doesn't have the bad side effects that some of the anti-inflammatories have. And I would also encourage and echo, if you're going to start anti-inflammatories, make sure you consult your primary care doctor. That way, there's no contraindications to taking those. And then kind of the last one, I think the last few years I've noticed, much more so than whenever I was in medical school, people focusing on mental health and how that plays a role in everyday life. I think that mental health issues are getting less of a stigma, which is a great thing. But it also has a significant role in the way the patient experiences pain, lives with pain, and how they can handle pain. And so there's been a few studies looking at how mindfulness meditation alone can help decreases patients' perception of pain, as well as increase their function. So there's multiple apps out there that you can look at, websites, things like that can be very helpful. So that's all that I have for you guys today. I know Dr. Reinches is going to be monitoring the questions and answers. So if you guys have any questions for me, please feel free to reach out. And then again, our Employee of the Month, Jason Calder, is going to be talking about the Move Plus program. Thank you very much.
Thank you very much, Dr. Woyski. That was a great presentation. In fact, I have a couple questions for the Q&A, or maybe after that. But let's welcome Jason Calder from our physical therapy department. And he's going to talk about a very innovative program that we have here at North Kansas City Hospital for people with both back and joint pain. So Jason.
Thank you, Dr. Righteous. Appreciate the introduction. Really, Dr. Righteous, we have you to thank, I think, for starting this program. About 3 years ago, we met in your office, and we were discussing this method of maybe helping people with chronic pain conditions to improve their function and really kind of move them forward when there aren't, it wasn't the time for a surgical procedure or they've exhausted surgical options. And that's really where the Move Plus program was born. We started that 3 years ago. We've seen many, many patients through that. When Dr. Woyski came to North Kansas City and started working with many of our patients here in the hospital, he brought forth the idea that if we got some of these total joint patients into the program, or potential people with chronic joint issues, that they might do quite well in a similar program. And we started bringing these type of patients in, and we've really seen some great benefits to a lot of them. So we'll be talking about the Move Plus program here. And Let's see here if we get our slides going. Yeah. All right, so the Move Plus program, again, is designed for chronic pain, pre-surgical conditions. This is a non-operative, non-invasive program. We really want people to understand that there are things that they can do before surgery that are going to make surgery much more of a positive experience for them. It's a progressive resistance program, and what our focus is really restoring function and movement. So a lot of people are chronic pain folks that come in with chronic joint pain or chronic back issues or fibromyalgia, that sort of thing. When they come into the program, we try to help them understand that the focus isn't on getting rid of all of their pain, rather really improving their function and quality of life. That's what we're looking at. And when we're able to do that, we find that they're much more successful if further medical intervention is needed. For a lot of folks, they're able to, when they see that sort of improvement, they're able to put off surgery for longer periods of time, or not have more medical intervention, which I think is great. Everybody would agree. So again, it looks at active, the Move Plus program looks at active interventions rather than passive. And so that means if you come to specifically for the Move Plus program, we're not going to be only doing massage or only specific exercises for the hip, where it's more of a holistic approach. So we're going to be working the whole body. And then we also focus on the science of pain, and that means understanding kind of what is going on with your body and the pain system. It is a very complicated system, and helping you understand that goes a long way to helping you overcome some of these chronic pain issues. What they found is that chronic pain is actually different than acute pain. So they've even done functional MRIs where they see the brain lighting up in different ways. And when they pinch people or they poke people, the brain lights up in a certain way. And when somebody has chronic pain that's there for a long time, it actually lights up different areas of the brain. So if it looks different in your brain, it has to be treated different. And that's really where, especially if you've been dealing with knee pain for a long time, that's been affecting a lot of aspects of your life, you might need more education, more teaching, more understanding of what's going on with you, so that when you do have surgery, or if you are having medical procedures done to help the joint feel better, that the pain system itself isn't holding you back. And so that's what we do, is we help decrease fears and concerns and work on trying to progress your function. So we also want to focus on, let me see if we can get the next slide going here. Yes. So, and again, what the research really shows is that as we progress, your understanding, again, it helps movement, it helps function. When the pain system is very elevated and protective, it actually changes nerve receptors. So you actually, around that maybe arthritic knee or that old high school hip injury that you had, as you have more fears and concerns, as you see maybe function declining, having to change from running to swimming or biking or something like that, and you're concerned, the concern itself can actually increase the amount of receptors you have in the nerves around those joints. And we see, as we decrease fears and concerns, the receptors can change. So our system is always changing. This isn't a head problem. It's not just, but it's not also not just a joint problem, especially if you've been dealing with it for a long period of time. All right, and so our Move Plus program, just to give you a little picture of it, it typically runs for about 8 weeks. We do 2 sessions a week, and the sessions are a little bit longer than what you would get for a traditional physical therapy program. They're 90-minute sessions. 30 minutes of that is individual pain education and coaching. on things like diet and sleep and stress management and again the neurophysiology of how pain works. And then we do group type circuit stretching and strengthening programs. So we kind of get a group atmosphere going because, well, it's a lot more fun, and having other people that are going through the same thing with you is often very positive. And then we do strengthening. We actually work on lifting weight. We do things that initially might be kind of scary, but we do it in a very gradual approach so that it's safe, for one thing, and your body can tolerate it. We're used to dealing with people with joint issues and chronic pain issues, so it is well suited for you. And then we also want to show you things that you can do on your own and either transition you to like a gym setting, or with some of our personal trainers here, or maybe the pool, but certainly giving you things that you can do at home too, so that you can progress. So a good candidate for our Move Plus program. This is typically you've tried exercising on your own. You may have tried some other conservative things. Maybe you've tried physical therapy before even and not seen the results you want. That would actually be a good candidate. If you've had pain for more than 3 months, and that's the big thing. This is not for acute injuries like I slipped and tweaked my knee or my hip. That's not in the short term. That's not a good candidate. You might benefit from physical therapy and certainly need to see a doctor about that. But that this is specifically for chronic pain, which is more than 3 months of pain that's been going on, and typically even 6 months or beyond. If you have had surgery like a hip or knee or back surgery, we're going to wait 6 months outside of that. So we want to be 6 months removed from any of those surgical procedures. Again, traditional physical therapy, you might do quite well with that, where we can tailor it to you. But if you've had a recent surgery, especially if you have precautions, we want to be outside of the healing process for that, so we can be reassured that that's going to be safe for you. Of course, if you have limited flexibility, endurance, and strength, if you've seen functional decline or disability, if you're challenged by movement or fearful, if you're afraid to do stuff, you're just, the doctor tells you, hey, let's go out and exercise, you're safe to do it, and you have no idea what to do, you're a good candidate for our program. So if you do have like an active issue like a pinched nerve or a spinal cord injury, of course, an acute fracture, or an instability in your spine, that wouldn't be the best candidate for our program. We want to make sure you have medical intervention to address that. Okay. And again, we take referrals from neurosurgeons, our orthopedic surgeons here, our pain management doctors, spine surgeons, and also primary care physicians now are referring to our program. It is billed like traditional physical therapy, so it is covered by your insurance, and we do need a physical therapy script for that. The outcomes of the Move Plus program that we've seen, the average is about 38% decrease in fear of movement. We see range of motions improve by like 21 degrees. We see weight being lifted off of the floor increased by 18 pounds. We see walking doing much better. Really kind of the biggest thing is how people feel like they're doing after the program. And typically people have said they're 75 to 100% better. The average for our program that we've tracked is about 65 to 75% improvement. So that's the actual number, but we have quotes of people saying they're 100% better after our program. Oh, I still hurt a little bit, but I can deal with that. And so that's really the big thing. Quotes have been like, I'm able to take less pain medication and return to activities, even returning to work at a very labor-intensive job that they haven't been able to do for years. And things like important things like lifting your grandkids and dealing with your flare-ups and that's really the key is getting the function to improve, getting you back to life and helping with fears and concerns. So why would you do the Move Plus program? Again, getting back to the things that you need to do, having group support, trusting your body again, and understanding your pain. These are the big things that we want for you to get out of the Move Plus program. I'm going to turn it back over to Dr. Righteous. I think he's going to take us through some questions that you all might have.
Well, thank you very much, Jason. I do want to tell one quick story of a woman that I saw in the office when I was a neurosurgeon. And I saw her 20 years ago with disabling back pain, and she had a lot of arthritis, and it was really limiting her life. And her passion was dancing and gardening, and she was exercising, but I didn't have any surgery to offer her. So that was 20 years ago. Interestingly, 20 years later, she came back to my office with the same symptoms. And that was after the Move Plus program had started. And I referred her to the Move Plus program. She didn't need surgery 20 years later. She just had arthritis and chronic back pain. She went through the Move Plus program and it changed her life. She was not pain-free, but she was able to pursue her love of gardening and her ability to exercise through the training and the learning of the Move Plus program. So I really want to congratulate you on that. So we do have a question, and this is for Dr. Woyski. Hello, I have an appointment at North Kansas City on June 16th with an orthopedic doctor. What can I expect from my first appointment?
I mean, that's difficult to say. I think every orthopedic surgeon is a little bit different. I think that, you know, again, it's going to depend on, you know, which joint is involved and kind of your reasoning to be there, sort of your age, activity level, and chief complaint. But I think in general, most patients, regardless of what is injured, are usually going to get some sort of radiographs. Hopefully you're going to see some smiling faces and some happy people whenever you go there. But yeah, I mean, my expectation, I don't know if it's through my office or not, but hopefully you're being treated very well with respect, get a good amount of interaction with the physician and physician extenders, and hopefully you leave the office with some sort of plan. It may not be the plan that you like or something that you want, but I'm hopeful whenever patients see me that I at least have a plan afterwards to make them better, whether that's non-surgical, surgical, or otherwise.
Okay, I have a question for you, and I think some of the listeners would have this. You showed really great x-rays. You showed x-rays of normal joints and joints that were diseased, but you also showed x-rays of joint replacements. In the picture of the hip replacement, I saw that there were 2 screws that were screwed into the bone. But in the knee replacement, I didn't see any screws. How did the knee replacement parts stay in the bone?
So there's essentially 2 types. There's press fit components, which have been around for a while, but the last probably 5 to 10 years, there's been, I guess, a bigger push to use them, especially in younger patients, where essentially, you know, the parts that they're machined into as far as the bone, they're just a little bit larger than that. So the bone will push up against the components. And then the fact that it's covering 2 ends of the joint that are weight bearing, essentially they get pushed up against each other and they should be good and stable. Part of that you could see in the knee x-ray, there was kind of this little flange that goes into the shin bone or tibia, and that helps with rotational control so it won't spin. And then on the end of the femur, there's 5 different cuts, so it kind of fits on it almost like a glove, so that it also provides rotational control. If it's not press fit, I'd say probably the vast majority of them nowadays, although press fit is getting more and more used, I think are just cemented on. And it's not necessarily what you'd think of as cement, it's more like grout. And so it's mixed with like a nice slurry, comes up thin, you apply it to the implants, and then it will harden. And as it hardens, it'll get a little bit warmer or hotter.
That's a great explanation. So here's one from a listener. Is running good or bad for our knees?
I think it really just depends. I mean, if those activities are really painful and sore for you, then I think you have to decrease the amount of running. I mean, if the question is it going to damage joints, it's very unlikely. Now, if you already have some arthritis or you have really bad malalignment, the increased stress that you put on your joints from running can make that a little bit worse. But there have been studies that looked at what happens to the cartilage in people that run and people that don't. That cartilage actually gets a little bit thicker. So in my opinion, I think in the right individual, which are most individuals, running are going to be good for your joints.
Okay, here's a question for both of you from a listener. My MRI scan showed a labral tear, a gluteal tendon tear, and impingement. Is surgery imminent, or could physical therapy potentially be the answer? I've been on meloxicam for 1 year with very little relief. And I would like the perspective of both the surgeon and the therapist to this question.
Good. You want to go first, Jason? I think you're muted.
Yeah. I think from a physical therapy standpoint, if you haven't tried it yet, I think that would be a good place to start. Of course, you need a referral from a physician. If you're on meloxicam, you've obviously been seeing a doctor. So if you haven't tried that, we want to start there just to optimize everything that we can. I think that with gluteal tears, those can be painful for a long time. We have seen improvement. Studies have shown improvement over time as far as the pain goes and function. It's depending on the severity of the tear, we're going to see different results in the physical therapy clinic. But the best thing you can do, again, is a lot of times those are really painful and we backed off of a lot of activity. We need to get you moving again. And if you haven't tried PT, that's a good place to start. Some of those gluteal tears, we'll turn it back over to Dr. Woyski to talk about that, because sometimes there is a surgical repair needed for that.
Yeah, so I mean, I think that's a perfect example of, why it's important to see a patient, do a good clinical exam, and where injections can be very helpful. So I look at a lot of hip MRIs, and you see a lot of accessory pathology, and that's the downside of getting an MRI, and I'm sure Dr. Reinsch can attest to MRIs in people that with back pain, is that you have to know, are those things really causing the source of pain, or is it just something that happens to be in your MRI? Given that you have a gluteal tear, I imagine if I looked at your MRI, I could probably find even a hamstring tear as well. And you just have to figure out what's causing your pain. So with typical FAI pain and joint pain, again, that's going to be more located in the groin. A lot of those patients will have pain in the groin with sitting, deep flexion activities, things like that. Gluteus medius and minimus tears often cause pain in the side of the hip. That can also cause pain with sitting, but usually it's whenever you go to stand from sitting for long periods of time, you'll have pain on the side of the hip. And you may be lucky enough that those both are causing symptoms. But I would echo what Jason said and start with physical therapy. Try injections if you haven't tried those. One, they can be therapeutic. They can also be a diagnostic. And if you fail those treatments, then in those instances, typically that would be a surgical solution. There have been a few studies that are very high powered. They're called randomized controlled trial, where basically you're randomly put into a surgery group or a physical therapy group. And they showed that both patients actually did well and improved, though the surgery patients for labral tears did better than the ones that were just therapy alone. But again, I think it just shows the power of physical therapy, that for some patients, it can get you over the hump. And if it doesn't get you over the hump, it gets you further down the road so that you can recover quicker if you do need surgery.
Okay, here's another question. I have been diagnosed by my doctor as having hip bursitis. What is the treatment for hip bursitis?
Again, I think for me, trochanteric bursitis or hip bursitis is smoke, not fire. So it's typically caused by something else. That could be you have muscle weakness, which is really commonly seen with that. You could have an underlying tear. You could have hip arthritis, and that's causing you to walk differently. And so then that's causing you to develop some bursitis. So if I'm seeing you for the first time, I'm again, probably radiographs or x-rays. I'm going to do a good clinical exam. I'll probably offer an injection if it's very painful. If you have a significant amount of weakness, then at that point in time, I may do an MRI, but typically I'll do injections first. And again, all my patients are going to go to physical therapy to work out those kinks to see, if we can get you optimized. And if you still have quite a bit of weakness after all that, then again, that's where I would typically get imaging. But.
Yeah, these patients tend to do really well with conservative management, and that would include injections, anti-inflammatories prescribed from your doctor, but also physical therapy intervention. Typically, it's an overuse type of injury that's caused by wearing of the band over the greater trochanter. So by strengthening up gluteal muscles, that's usually where we start. So really strengthening your hips is the key, correcting some faulty movement there if possible. And our patients tend to do really well with a combination of good medical management and physical therapy, exercise, and stretching.
Okay, I have one last question, and I want to preface this question with something that's very common to your patients and my patients. Here's where it starts. First, I live alone and don't drive. And here's the question. Are there additional or special constraints with shoulder pain and with shoulder replacements? How does someone recover? And I think if we can expand the answer to include how does someone recover with knee problems, hip problems, shoulder problems, who lives alone and doesn't drive.
So from my standpoint, I mean, again, my main goal is to get you better. And in some patients, they have a very difficult situation that may be a living situation. They may be moving, a stressful job or something like that. And so you may just have to counsel those patients and say, well, at this point in time, surgery is not going to be right for you. Because the last thing you want to do is go through a big surgery, leave a patient alone on an island, and they're going to struggle and not do well. Again, surgery is just one time point in the overall care of a patient. There's before surgery, and there's a huge part after surgery. And if you feel like there's certain constraints in the patient's life that they can't go through with that last part or the after surgery portion, then that may need to be held off. But with that, I think especially here at North Kansas City, they have very good options for patients, whether it's inpatient rehab, which has been much more successful than when I was in fellowship and residency and getting patients in there. They do an excellent job here. Skilled nursing facility, home health, they run the gamut. They're starting to expand their physical therapy offices elsewhere. And so maybe you can't get to physical therapy, but maybe physical therapy can get to you. You may not be able to get to your physician's office, but now we're doing telehealth, and maybe we can come into your living room and do medical visits there. So there's a lot of options for the quote unquote non-traditional type patients.
Thanks for that comment. We do have excellent home health here that's been nationally recognized. Well, I want to thank both of you for joining us today, and I want to thank our guests. We have gained great knowledge about how our orthopedic team can treat your hip and your knee pain so you can get back to doing what you love. If you would like more information about our orthopedic services, visit nkch.org/ortho, ORTHO. Thank you very much for attending, and everyone have a good afternoon.
Thank you, Dr. Righteous.